Okay, so the webinar is now live, and I just want to say to people who are in the waiting room that we will formally start at 2:05, which is just in a minute, following MIT protocols that we start at 5 after the hour, and we end at 5 of the hour. So I will do formal introductions in just 1 minute. For those who are already here, if you want to think about, as you're listening to the talks, if you want to think about questions that you want to ask, please put them in the Q&A function. We will see them. We will try to get to them as best we can. I will moderate. So it's now 2:05, so we can formally start. I want to say welcome to everyone. Welcome back to the History of Now, Plagues and Pandemics. Today we will be talking about demography, which is, after all, the study of populations, and biopower, how governments strive to study and control these populations. I'm Elizabeth Wood from the MIT History Department, and I will be moderating this panel with John Brown and Anne McCants. John Brown is professor of economics at Clark University, where he researches and teaches on topics in urban economics, international trade, and historical demography. Anne McCants is our own Margaret McVicker Faculty Fellow and Professor of History at MIT. She's currently serving as president of the International Economic History Association, and she's also head of Concourse. So thanks for joining us. As many of you will remember, our format is to have about 30 minutes of discussion with the speakers presenting, and then we'll take questions and answers from the audience that I will try my best to moderate. The speakers and I have agreed that we will have 3 principal questions today. Starting with the question, we know that there are substantial disparities in the rates of infection, severity of illness, and mortality in the current COVID pandemic, cleaving along lines of pre-existing health conditions, income, ethnicity, and geography, among others. So I'm going to ask our 2 speakers to think about what do we know about earlier epidemic episodes that help us understand these cleavages. A second question will focus on how should communities intervene in the face of epidemic disease spread? How have different public health interventions and public reactions against those interventions taken place in the past? And thirdly, how have people understood the diseases that they are dealing with different vectors of causality? And how does that understanding of causality affect their understanding of the disease itself? So without further ado, let's turn the mic over to John and tell us about the case of cholera in the 19th century, the disparities there, what difference does it make? And then after that, Anne will talk about the plague in the medieval and early modern period.
Thanks so much. It's great to be able to share this conversation with everyone. Cholera itself is a disease that is really counted in the early 19th century as one of the big pandemic diseases, really a focus also of public health and governmental concerns. So we typically think of cholera, the Black Death, which are plague, and finally then also yellow fever, which I think was the topic of an earlier conversation. Cholera actually appears in the first pandemic in 1817, mostly in East, South, and Southeast Asia. It comes from basically India, and then it spreads to other parts of the Asian continent. It makes its first appearance in Europe in the 1830s, early 1830s, coming from the East. And it's typical then of the remaining main cholera epidemics. There were actually 6 through the end of the long 19th century, which we historians say basically ends in 1914 with World War I. There were basically 6 main pandemics that took place. And the ones that actually first attracted European attention was actually the second pandemic, 1829 to 1837, that actually struck Europe and eventually also made its way to the United States via Quebec and Montreal into the United States through various directions. And then finally, there's another pandemic in the 40s, and then last big pandemic that hit Europe was in the 1860s, early 1870s. And so that's where we really had a turn in the perspective of public authorities towards what might be actually the best measures are towards combating cholera. Cholera itself was actually believed in the 1830s. This is part of the discussion we'll have later on what the theory of disease causality actually was. But cholera was actually believed to affect more likely those who are perhaps poorer weaker, and also perhaps also of intemperate attitudes and habits. That is maybe too much drink. And so uh, definitely there's a connection by the 1860s between cholera and living conditions, a belief that by that time, that poor living conditions, crowded living conditions, poor sanitation, and so forth. For example, using your chamber pot to dump it in the wrong places, so it may actually be affecting the immediate surroundings where you live. Those all actually were things were associated with cholera, more likely to be associated than also with lower income people. And people are weaker, so maybe children, the elderly. One other feature, though, of cholera was actually that it's a little bit more, and that's what I wanted to share with you, a little bit more than just simply a question of the uh, of of poor urban living conditions, which is clearly also part of the conversation from the 1830s, the first big pandemic, cholera, to strike Europe and also the United States, going through actually the 1860s and later. So one striking feature of cholera epidemics uh, in Germany in particular was actually that it tended to strike the areas that I just will make a note, basically were the places far to the east. This area is called East Elbia, is area of large landed estates, uh, agricultural laborers and so forth. Uh, and relatively low population density, contrasting with the industrial areas viewed as being to the west, and then also in, they say, the Ruhr Valley and the industrial areas of the Rhineland. So strikingly, this urban-rural split that one might have assumed from looking at other kinds of earlier and even contemporary discussion, I think part of the puzzle was you did see so much of the cholera actually hitting these eastern provinces of Russia very, very, very strongly. So there's cholera presents, in that sense, a fairly, for contemporaries, I think actually a mixed and puzzling picture. It does seem to be affecting the kind of people we think it should be affecting, but also it's affecting other people who we don't expect. I think in the Prussian case, actually, the story was they're consuming too much of the local liquor that's actually kind of too much schnapps. Basically, consumption was explaining that.
John, if I can add a thought to that particular cholera narrative that's I think really interesting. We have this same sense that urban places are where, that are filthy, they're crowded, it's where poor people live. Of course, that's not true anymore today. It actually is where wealthier people tend to live. But cholera, even though we think of it as a crowd disease, one of the most striking set of cholera epidemics in North America was actually along the Platte River, hitting wagon trains heading westward along the Oregon Trail. And those were not dense populations. They aren't now even. And I just think really interesting, the map you've shown us, what that suggests about a counter narrative to our standard one, especially for the 19th century, that cities would have been squalid and a place where disease proliferated. Can you add anything about income groups, perhaps?
Well, I think we know in historical demography, a big piece of historical demography is trying to understand the big mortality decline of the 19th century. That's really one of the number one of two main questions of historical demography going up through the First World War. And I think we did see, for cholera, and of course generally for infectious diseases, a substantial mortality income gradient. So we know that for all the diarrheal diseases, for example, that obviously are not simply pandemic diseases, but are more broadly endemic in the population, that was clearly a problem because there was clearly an association between mortality outcomes in general and living conditions, particularly with respect to sanitation, water supply, quality of water supply. As I've noted, also disposal of human waste was really a key issue. So the kinds of things, and access to water, just the practicing washing hands was really not possible if you had to take a trip out to a pump just to get access to water, which was the case for most urban households. So I think that this mortality grading was actually a pretty substantial issue. Studies also of cholera during this time, the 19th century, could be uh, extremely focused on individual cases, identifying what they called house cholera or cholera houses. They're also typhoid houses. And these typically more likely to be found within, say, the old city walls rather than in newer areas outside the city. The housing itself, there were cholera-proof houses built uh, allegedly in the early 1830s in Britain in response to what looked to be a really high association between very poor and crowded living conditions and actually the incidence of cholera. So there is clearly an income gradient that's active in cholera, and actually, of course, with all mortality experience in the cities, but also clearly also in the countryside. That was also the case.
Elizabeth, would it be okay if we turn to the plague then?
Yeah, let's turn to the plague.
Okay, well, so I mean, it's interesting to think about the second great pandemic of plague, which begins with the Black Death, 1347, 48, 49, 50, 51, depending on, where you're looking in sort of Central Eurasia or in Europe. And one of the things that's really interesting about that first episode in particular is that there is not a big divide between urban and rural mortality. And I mean, obviously, our data is not as good as the kind of data that my colleague John has just been showing us, where we can map mortality, sort of down to the precinct level. But all the evidence we have suggests that rich and poor both suffered from that first pandemic, maybe not equally badly, but that the suffering was widespread. And I mean, the one thing that rich people could do in the face of plague was try to flee to some remote place if they had a country estate. And of course, Boccaccio's Decameron is set in just such an elite escapist retreat where 7 noble young people go to tell stories to each other to pass the time. But in general, our records suggest that this was not very effective, and that rich people died right along with poor people. And now whether this is it's a good thing from the sense of equality, but it's a bad thing from the sense of the overall mortality, which in some places was as high as 50 or 60%, a loss of the population in the space of a few years. Later episodes of that same great pandemic, that pandemic is understood by demographers to have lasted for about 3 centuries, coming in waves, subsequent waves. And those subsequent waves appear to have behaved rather differently. And this is actually, I think, one of the remaining great puzzles for historical demography, is explaining how that first outbreak in the middle of the 14th century behaved so differently from our expectations, as well as from later waves of bubonic plague. But we have good Italian evidence in particular, from the 16th and even into the 17th century, that suggests that income gradient that we're so familiar with returns in spades for the plague, and that poorer people really are more susceptible both to infection and to mortality in these later visitations. And there are many theories why this would be the case, but I have to say, I think it's unsettled territory for historical demographers. I mean, the obvious answer is that they had fewer resources to protect their health, and they probably had lower health standards to begin with. But plague is something of a non-respecter of initial health conditions, which does appear to be very different from cholera. as well as certainly from the coronavirus. But it's a very different vector. It's bacterial, and in the absence of antibiotics, most people were equally susceptible. And so the bigger issue was keeping yourself separate from the bacteria. And we can talk about, how do different diseases actually spread, and what theories did people have about how those diseases spread, to think about, sort of how do you keep yourself away from the bacteria? And maybe, I don't know, John, should we turn to that next?
Well, I had a question actually, because I don't know that much about the plague, and particularly even this first episode. Did we see differences? I think about disease causality as having definitely a vector, and the vector, of course, then influences your exposure risk, as well as then your ability to resist whatever is actually potentially affecting you. And I'm wondering, do you see changes between the 14th century and say later episodes, 16th century, 17th century of the plague? Are there differences in the spatial organization of cities? Do we see an urban-rural divide emerging during the later episodes that did not exist before? I'm kind of curious over those aspects of what we see emerging as this, as you said, a notable income gradient that had not existed before.
That's a great question, John. And certainly as Europeans, which is the material I know best, as they become more familiar with the disease and what they observe to be true about it, even if they don't understand the bacterial connection, they do develop new strategies. And one of them, of course, is the quarantine. And I mean, perhaps that's the most famous of them. In an urban area, quarantine was a little bit of a double-edged sword, right? You could try to quarantine the disease out by closing your city gates and not letting anybody in, but of course you might also quarantine the disease in, and not let people escape away from it. So there's an element of luck to that, right? Sort of how quickly and how effectively you manage to quarantine. And also how long you had to do it for, because if you've really kept goods from coming in as well, you begin to have food shortages, which is obviously a serious problem in its own right. But there is some reason to believe that cities in particular were better able to anticipate both having food supplies in reserve. They had the capital and the coordination, right, that's required. They had city governments that could have food reserves in advance, and then they had a physical barrier. They could keep people and goods out, and it probably did make a difference. Paul Slack, who's a English historian, has written a major book on the effectiveness of quarantines, and he kind of, by the end, he says, well, it was a 50-50 proposition, that, it could be very effective, but it might also be catastrophic. But I think that does change the shape of the disease. I mean, the other issue, John, is that first episode, the plague is everywhere. And in subsequent waves, London will have a visitation, or Marseille will have a visitation, or the German lands will have one, right? But it never again does it go everywhere in, sort of Eurasia simultaneously. And I think that also makes a difference for people's ability to navigate their options.
That sounds great. I actually think it would be great to hear John on the subject of quarantines. I know in Russia, where they had huge the six cholera epidemics, they had riots over the quarantining. So I'd be curious how people in Western Europe tolerated attempts at cholera quarantines.
Yeah, I think that's an interesting question. And I've been reading just recently, because I'm also doing a little bit of a pandemic seminar for my undergraduates, the work of Akerknecht, who's written about the kind of the emergence of the anti-contagionist perspective in disease causation. And it turns out, I think, that even in the 1830s, the pandemic was moving from east to west, from Russia in particular, coming west. That there was already pretty early on there were some different delegations are sent to Russia to see what's going on here and coming back, and they're kind of outpacing the cholera because people are still moving relatively slowly those days, and they're discovering that the quarantines don't seem to be very effective, and so there's actually a pretty I don't think there's ever a real effort in the same way there might have been during the various visitations of plague to institute thorough quarantines of cities and kind of lockdowns like there would have been. I mean, there are kind of scattered efforts here and there, but not in the same degree as kind of anticipating the plague. We know the plague is here. We have to actually start our quarantine and kind of shut off our city, close the city walls, and so forth. So there's also a little bit of it starts to then, there's a very nice piece written about the cholera epidemic and kind of the assessment of it in New York State in the early 1830s, the first epidemic, and kind of when the cholera would hit, they'd have lots of commissions and studies and going to visit all these places to find out what happened. And already early on in the 1830s, you start seeing then the emergence of then an anti-contagionist view of cholera, that it really can't be transmitted by person-to-person contact or a diseased person's in contact with the diseased persons, or alternatively, diseased items, food or clothing, getting in contact with individuals. So this anti-contagionist perspective actually also starts to pretty quickly takes over in terms of the policy recommendations. So the quarantines don't take on the same role, except later on when we actually have the discovery of the cholera bacillus, and then a pretty dramatic turn takes place once that actually becomes accepted policy, and it's really quite contested.
Very interesting. And what about the relationship between understandings of the causality of the disease and responses of governments, local and larger?
So this is an interesting problem, Elizabeth, for plague in particular, and maybe has some resonances for us with our current situation. Plague actually can arrive in three different forms. There's the bubonic, the pneumonic, and the septicemic. And it's all the same bacillus, but it depends on how it enters your body and how quickly it overwhelms your system. And that's why we have very different descriptions of how long it takes for people to die. There's the kind of standard Boccaccio description of, they develop the bubo, that is to say, the boil, the distinctive boil in the lymph nodes, from which the bubonic plague takes its name. And then it takes about a week, right? But in fact, Boccaccio also tells us that there were people who were healthy at lunch and dead by dinner, right? And those poor souls have clearly had the poisoning of their bloodstreams, which happens very quickly. So you can pick up the bacillus. Maybe the most common way is to be bitten by a flea that is carrying the bacillus in her stomach. And then when she bites you, it goes into your system through her saliva. But you could also be attacked by an animal directly. And we know in the southwest of North America, that occasionally somebody picks up the plague, and it's often because they've encountered an infected squirrel or an infected cat. There's a there are actually a great many animal vectors, as it turns out, that can carry the plague. But you could also pick it up from another person. If somebody has an advanced case and the bacillus is in their lungs, and then they have respiratory discharge, so sneezing or coughing, or, coughing up blood in particular, and, then you pick it up directly into your respiratory system. And typically that is it's more lethal and it's faster. And then, as I said, there are those few unlucky souls who, for some reason, it infects the bloodstream directly. And so it's very difficult, I think, for people to accurately assess by observation where the plague is coming from. There's kind of a standard popular narrative that, well, people in the Middle Ages, they didn't really know anything. And so they had all these misguided notions about disease. And, that's not really being very fair to them. Just reading the evidence would actually have been very, very difficult. I mean, as John notes, for the 1830s experience with cholera, until you know what the bacillus is and what it's doing, it's actually very difficult to read the observational evidence. And so you could shut your city off, but that doesn't keep small animals like rats from, making their way through that closed portcullis. And so even quarantine, it's fairly effective with plague, but it's far from foolproof. And you could pick it up from people's clothing, because the clothing of a deceased person may very well have fleas residing in it. And so it was incredibly difficult for people to understand the vector in a way that would give them sort of, clear, common sense solutions for public health.
Yeah. And I imagine, John, you've got the same thing with cholera. It's very hard. It takes a long time for people to identify that the virial, or whatever it's called, is actually in the water.
Yeah, I mean, but in the case of cholera, it's kind of interesting because up to the early 1830s, really the standard approaches to disease causation were either contagion, either by personal contact, or fomites, that is by some object that actually has been somehow or another affected. But I don't think it's contagion, but I don't think there's not a sense of necessarily having a bacillus or something else. It's just basically that's how it gets transmitted. And so the evidence that seems to pile up against the effectiveness of quarantine measures then pretty quickly turns to attention towards then a very spatial, localized view of cholera. Even though they know these pandemics, they can see the following rivers. The 1830s, I don't have it on the map, but if you follow the 1830 cholera pandemic, the first one in Germany, it just follows the rivers into Germany by river traffic, because that's really pretty much how the most effective movement of people and goods took place. And so they could tell this is happening, but they at the same time they couldn't in particular, they're puzzled because those who were taking care of the cholera victims were not getting sick. So the observational information was completely contrary to a perspective, a contagionist. So then they start looking then at localized conditions, and I'd say maybe 5-10 years from now, Akerkanesh suggests 5 or 10 years, 15 years, different. The French actually are very big leaders in this. The Americans are too. The anti-contagionist perspective takes over, and that's the miasma. So cholera is a local disease of polluted soil, air, and water. And so then, of course, you don't want to quarantine someone because you're putting it's like, it's today in the COVID situation, COVID-19, you don't want to be in a small room with all sorts of other people who are potentially affected. Same thing, the miasma view said, no, we have to open up windows. We can't have people stuck in their homes. So we don't want to be, there's arguments against a quarantine. And it turns out it's kind of one of these most interesting episodes, I think, of the emergence of an etiology of disease is that the anti-contagionist perspective pretty much sweeps the ground. Every respectable medical society is anti-contagionist, and they're pro-miasma, and that then leads to, surprisingly, then an effort to clean up what are the sources of smells and odors and start cleaning up cities. And hence my chamber pot has to give way to initially privies, which are a pretty important step towards better sanitary conditions, and finally the flush toilet. Hamburg actually is a big leader in providing water supplies and also sewers. Of course, I'm also sitting in front of a picture of Hamburg in the last big epidemic of 1892, because their water supplies, unfortunately, were not filtered or otherwise prevented from actually being cleaned, so that people were drinking water that was full of the cholera vibrio when a group of immigrants came from Russia going towards the New World and happened to also be infected with cholera. But it was actually, that was really a conquest. So by the time my map of 1860s shows up, by that time, actually, that's the last big pandemic that affects Germany. There's other outbreaks. And so Europe, even though the measures are already in place that have actually stopped the spread, but for the wrong reason.
Right. You know, John, this, I think, just leads right into our last theme, which is that assessing causality is incredibly difficult. And we struggle with it today. And certainly those who came before us struggled with it as well. And, you know, sometimes you do the right thing with the wrong theory. And, you know, cleaning up the water supply in urban spaces because you thought that there were miasmas, you know, from our point of view, well, that's the wrong theory, but cleaning up the water supplies is really a good thing to do. And so, you know, I think it's really important for us to have a great deal of humility, right? As we march around our own lives, confident that our causal notions of how things work, you know, are accurate. I try to remind myself of this, you know, periodically.
Also, I wonder what this raises about the question of public health. When do they go from thinking we're just going to treat the patients, isolate them, deal with them, and when do they begin thinking about the sewers, what Russian would call canalization, creating the underground network structures and creating public systems of response? How does that time frame work for your two cases?
Well, I've done some research on German cities during kind of this actually bridging the period of the last major pandemic attack on Germany. I think maybe 200,000 people were killed in Prussia on my map from the 1866-67. And it is really which is also a bit paradoxical, the public health movement definitely is focused on attacking the sources of miasma. So you go after the cemeteries of potential source, the piles of manure, let's get human waste under control. At the same time, though, what might have been most effective, which would actually be clean water supplies from sources that were unimpeachable. Unfortunately, the Hamburg source was impeachable. It was really early source of water, but it was also quite impeachable by they also had typhoid epidemics in Hamburg for similar reasons. But it was actually cities started going after the clean water supply because they were looking for purity. They were looking for physically nice water. So the German cities in particular actually went after improving conditions, somewhat maybe a little bit because of past disease experience, but much more trying to actually keep up with the British and other places that were advanced countries. You know, if Cologne or if Hamburg or Berlin or Dusseldorf are going to be advanced cities, certainly we should have running water available for our people. And eventually also, we probably want to have some better form of disposing of our wastewater. And maybe in the end, we'll actually connect our we'll actually have flush toilets, which in German cities is actually relatively late innovation, even after they had plentiful water supply. So it's paradoxical that the public health movement is pushing for this. In German, it's called the Assanierung der Städte, so cleaning up the cities, but it's cleaning the streets, and it's a little bit. It is a concern about public health in a general way, but then actually, I think once you get a turn towards kind of bacteriology and thinking then about the germ theory of disease, in some sense, you start getting a little bit of a retreat from the earlier mid 19th century notions of what constituted public health.
Yeah, I would just add that miasma theory is terrific for public health. Germ theory less so. And maybe that seems ironic to us. We haven't talked about malaria. We're not going to, but I'll just say briefly that early modern Italy, sort of Renaissance and early modern Italy, it's really where public health becomes a phenomenon first in Europe. And some of the early efforts, of course, are around plague, but also the concern that swampy land, of which coastal Italy has a lot, that it has lots of bad miasmas, right, coming up out of the swamps. And so if you drain the swamps, you get rid of those miasmas. And of course, if you drain the swamps, you lessen the mosquitoes. And so very quickly, the miasma theory that leads to these public health measures is actually confirmed. Right, malaria rates go down very dramatically in ways that significantly improve people's quality of life. So, I don't know, maybe we need to bring back at least just enough miasma theory to keep a public health system in place. I'm not sure what the policy recommendation is here, Elizabeth.
That sounds great. Wait, John, get it, whatever you want, and then I should turn to the questions from the audience.
I just had one other. So I think it's actually the other piece of it is, at least in the conversation in the 19th century, and just reading the accounts of city council deliberations in North Dakota over whether we should have a mask mandate in the face of the worst infection rates in the entire globe. These discussions actually were very important in the 19th century too. Economic liberalism, the idea of free markets, open choice, free commercial traffic, which is also clearly something you don't want to impede if you are going to. Quarantines are clearly against the basic principle. All those the emergence of public health as an approach to how to deal with city life is in this ongoing semi-conflict with then economic liberalism, and it takes on different forms. Where that conflict ends up takes on different forms, to the extent I think that the central government and the public actually are willing to accept a more interventionist central government. So in the end, German cities become the leaders in public health and general kind of social well-being measures, because they tend to be actually much more administratively powerful than would be, say, American or English equivalents. And economic liberalism hasn't quite taken on the same total control of the conversation in Germany as it did in England, and certainly also the United States. So we're seeing this conflict once again clearly between choice, individual decision making, and how people perceive threats, and then obviously the spillover effects of those people's actions based on their perceptions. It's playing out again in a very striking manner.
Oh, fantastic. Yeah, no, I think this is a really great point, that the challenge over what do you attack, and in what way, using what mechanism, and how do you, societal values, how do they come directly into conflict with what might be best from a public health perspective? Yeah. We have 9 fantastic questions. They're varied and diverse, so I'm not quite sure. There's one quite at the end that seems most close to what we've just, the first one to bridge to. It's a rather long question, so I'll just simplify it. But the questioner says, I'm very interested in this conversation about closing off towns, building up walls to manage the spread of disease. These efforts didn't work because disease-bearing seafaring critters, water, et cetera, could get through the walls. Social and not just physical walling practices are, of course, still important today. Can you reflect on the change over time and how boundaries and borders, social, spatial, economic, have been reconceived during pandemics past? I'm thinking here about the new importance of state and city governments. This is what you've just been talking about, John. In managing COVID, but also about social divisions among various classes, and maybe even the fact that leaders of the US government continue to build on the southern border, that wall that they think they can spend COVID money on, that Congress appropriated for, boggles the mind in terms of breakdown of understanding. Summarize, can you link the history of wall boundary-based thinking to our own moment and to COVID?
Well, maybe I should start, because it's at least in the Western experience, it's a medieval phenomenon to build walls around cities. In antiquity, cities were not walled very explicitly. And so this notion is a medieval one that carries forward. And we think of walls primarily, I think, today as a way to keep things out. I think for many medieval urban thinkers, if you will, or rulers, the wall was at least as much about keeping things in as it was keeping other things out. And it had a really powerful economic role to it if you had a guild system that dictated, sort of which products could be produced and sold in a given place, right? You needed to have that place really well demarcated, and the wall provided some of that, right? So we have legal disputes about guild production, where the language is literally, something was made outside the walls, right? So the wall has this very clear economic quality to it. And then when you have a disease outbreak, the wall is already there, and the concept of the wall is already there, and what it's supposed to do for you, right? So you don't have to invent it. I think one of the things that's interesting about our current moment is, of course, we live with cities where you can't even tell if you missed the road sign, when you've entered and exited, right, from one place to another. And so for people who are thinking about walls, they actually have to invent it in a new context. Whereas for 14th century Europe, they were already there. They were in place. They had another function, and this function could just be added on to them. I don't know if that helps answer the question.
No, I think it is interesting, because I think what you're suggesting is that some thinkers in the United States are going to a medieval model. They want to build walls with other countries. And others are struggling with, for example, in New England, if you go from Rhode Island to Connecticut to Massachusetts, can you say we won't let the Rhode Island people in? Well, absolutely, actually you can't, barring new. So that definitely relates. Is it a medieval, or is it an ancient model, or is it a modern model? And is it economic, or is it public health? John, how do you want to weigh in on this one? I think it's very interesting.
It's striking that actually, so the 19th century is really then the period, of course, when all the major cities of Europe tear down their walls. And they're also, and it's part really also of this, it's also the end of restrictions on movement, on guilds. So it's really the opening up then of generally the liberal economic order we're familiar with today. There was one other, when reading this discussion in the 1830s in England over the first measures taken to deal with cholera, and then the quarantines that were put in place, it is striking the kind of another feature of our, I'd say, social class wall building, or kind of maybe some of the differences that emerged between different groups over attitudes towards the other side, really, people's behavioral choices emerges then. So you actually get a combination of both free trade, manufacturing liberals against these quarantine anti-cholera measures, but then you also get the pro-Chartist, that is pro lower middle class representation in parliament people also saying cholera is a hoax. And so in a way, the political conversation reflects to some extent people's own, I think, perceptions of their interests as well as then what they'd like to believe about the situation. And that, for me, that had a lot of reading about that had so much resonance with today, where there are actually different, they're pretty clear. We can't, we have our little mini walls when we're closing off bars or taverns, right? I mean, we're basically, we're restricting people's ability to go to certain places. We're creating very small islands of where you can't go, where we know you could have a higher risk of infection. But at the same time, there's also economic interests. For example, the Tavern League in my home state of Wisconsin that are violently against these efforts that are viewed once that truly then would clearly have a very positive public health impact. So I think there's this other aspect of the people's perception of the disease and then their economic interest plays a role too.
Yeah. Another question, where can one learn about the early debates about the birth and development of public health? When do states start funding public health efforts? Are either plague or cholera foundational to such government municipal efforts? I mean, somewhat you've answered this, but I think it's worth just, who debated these issues? Health professionals, religious leaders, government officials. You've also mentioned business leaders. How did that all come together in the plague case, for example, Anne, and then John on cholera?
There's a classic old book now by Carlo Cipolla on plagues in Italy and public health measures. And I think, it's a little book. You can read it in an afternoon. That's where I'd start. But the kinds of public health measures that John is talking about in the 19th century, I think are really a different thing. Those walls coming down and the emergence of liberal economic ideas, there's a real divide between what would have constituted public health in the sort of Renaissance, early modern Italian context that Cipolla writes about, and the kind of thing that John has identified as more, well, I'll just say more modern.
I think I think there's a book called The Cholera Years, which is a nice starter. I think actually the Hamlin reading gives you some nice references. So Hamlin is a very highly respected voice writing about 19th century policy. It's interesting. I think the initial cholera, the first epidemic, actually seems to have had the biggest impact on the public and the conversation. But then, of course, real measures took many, many years, and of course they're also, as we've noted, for the wrong reasons, to actually be enacted. So it took 1848 is a very single year in British public health history because that's really the first Parliament acts to really try to provide some foundation for funding and also for measures to deal with public health issues. But it's a conversation that actually initially has a very strong moral content to it. It continues to have a moral content to it. It's social workers at the end of the 19th century. It might have been preachers in 1830, but there's still this is kind of a social conversation that's actually a classist conversation. There's also a medical conversation that comes in and out, and so and there's also clearly also strong economic interests that are for or against what at that time were extremely expensive measures and undertakings for particularly for cities or municipalities. So it's actually a very interesting take on how 19th century society actually dealt with a whole set of issues. But public health is a really nice one to look at.
Oh, that's great. So let me try and fit one more question in, and then we're going to have to wrap up. The very first question we got today was Black Death. It's for you as demographers. It related to Anne's point about income gradients, but it's a slightly different question. It's very simple. Black Death made rich richer as it happened with COVID. Do you guys know anything about outcomes from plague and cholera in terms of who survived? I mean, we know peasants were better off in terms of bargaining position if they survived Black Death, but is there anything else you want to say about the impact on wealth after these illnesses?
I'll just say very briefly, the 15th century is often referred to in Europe as the golden age of labor. The sheer quantity or the sheer magnitude of the population decline means that the bargaining power between labor versus holders of land really shifts. But I think maybe John will have a more contemporary perspective on the specific relevance of this to the COVID situation.
Well, I'd say that, so the cholera per se, it has, for the most terribly affected areas, is maybe a mortality of 1% to 2%, which is quite significant. It's a doubling, or certainly of average annual mortality in terms of excess mortality. So it doesn't really give you that dramatic impact as a Black Death. What I think it does do, and then I'll tie it back then to launching conversations about social economic living conditions. So a very large part of European impetus towards improving city living conditions comes out of this initial exposure of the conditions of the poor associated with going to the homes and seeing the extent impact of cholera. So and why cholera is taking place. So I think it's actually this gradual awareness that we're in it together to some extent, and particularly in the German case, it's actually because the German industrialists want their workers to live, that they actually see a really strong interest in trying to improve the overall social living conditions of the population. So it's kind of paradoxically, it actually has an evening effect. At the same time, though, depending upon in other situations, it's really going to be also, you're still going to see the wealthiest doing better than the lower income people, but everybody's on an escalator that's actually not golden. It's not coming down. It's actually ascending in terms of reducing overall mortality levels in the society.
Yeah. Oh, there's so much more we could say, but we are at 2:55, so we should end with a huge thanks to John and Anne. This has been a fantastic, stimulating conversation. I want to just mention to our audience that next Friday, October 30th, the topic will be public health, biopower, and inequality with Carlo Caduff, reader in the Global Health and Science Medicine at King's College, and our own Amy Moran-Thomas in anthropology at MIT, moderated by Dwight Banerjee from the STS program. So come back next week to keep thinking about how do public health, biopower, and inequality interact in exactly these ways. Thanks again to John and Anne. This was really fabulous conversation, and see you all next week.
Thank you all for organizing it.
We really appreciate the chance to share this conversation with you all.
Great job.